and development assistance. I think we need to say that out front. But at the same time, Tanzania is working hard to translate the impressive gains that it's been making economically in the same period into real improvements, broad improvements in people's lives. And as we know, sustaining life itself in all of its beauty and mysteries is actually the point of economic development. And healthcare is one of the greatest expectations of people everywhere. Next slide. And yet we know that in the medium term, in lower income countries that have GDPs per capita, say, of less than $2,500, we are far from having the domestic resources to provide even the most essential health services. And as we found in the Lancet NCDI Poverty Commission, non-communicable diseases and injuries account for the largest gap in health financing towards universal coverage, health coverage. And we projected that this will be the case through the end of the decade, even with very optimistic assumptions about revenue generation and government expenditure on health. Next slide. Penn Plus is one solution to this impasse, and that solution is integrated delivery models and integrated social movements. The solution is integration of national commitment and global solidarity. Because Penn Plus brings the passion of 3 childhood onset disease communities: sickle cell, type 1 diabetes, and rheumatic and congenital heart disease. And it empowers nurses and mid-level providers to deliver services for these conditions at primary referral facilities close to where people live. Next slide. As noted in a recent editorial from the editors of the Lancet Primary Care, these Penn Plus providers are saving young lives immediately, but they are also driving broad improvements in chronic care systems at primary level and in referral services as well. Next slide. Now, the reason that we are here is that, as we've heard, in 2022, all 47 member states of the WHO Africa region, including the honorable ministers that are here with us today, committed to the Penn Plus strategy. And the express target was Penn Plus initiation in 70% of countries. And we are well on our way to that goal, as we've seen from Dr. Nyarko. And many countries in the region have actually published detailed Penn Plus national operational plans to guide service expansion, as we'll hear more about at this conference. But we know that the target that we are really aiming for is the target of getting people high-quality care at large scale and bringing them out of poverty. So today we are discussing the findings from a modeled investment case that shows what is possible to achieve together over the next 10 years. Next slide. The point of the investment case is to get a sense of the resource requirements at scale and also their composition, particularly in terms of the major drivers of cost. And we'll want to understand the potential impact we could achieve in different scenarios. And finally, we want to quantify the return on investment in terms of benefits and costs. And I will give you the headline, the spoiler, that Penn Plus is a best buy for health systems. Next slide. In order to conduct this investment case, we had to develop realistic scenarios for scale-up, including what we know about the current pattern of Penn Plus expansion and the limitations that are imposed by the time that it takes to train people properly. And we had to develop disease-specific Markov state transition models of health impact for 7 different diseases, many of which had never been constructed before, across 3 groups of childhood onset conditions: diabetes, heart disease, and sickle cell disease. We estimated country-specific costs using competitive reference prices for tradable inputs. Next slide. We looked at 2 different scenarios for scale-up. One scenario assumed that financing for Penn Plus expansion would be entirely based on domestic resources. And we grounded this in Ethiopia's Penn Plus National Operational Plan, which is really an impressive document that you all should take a look at. This plan assumes that more than half of the cost of scale-up could already be addressed through improved efficiencies in the use of existing staff and space, with new contributions from government revenue and insurance payments on the order of 1% of total government expenditure for health. In the second scenario, we looked at the potential impact of blended financing with external contributions coming from integration of disease-specific philanthropy, alignment of private sector support, and contributions from multilaterals like UNICEF and bilaterals like the Scottish Government. In this scenario, we still had the same limitations around the logistics of training, but financing was no longer a bottleneck. Sorry, go back. We found that in 2035, there would be 1,046 clinics supporting 650,000 people in the first scenario, as compared with 3,418 clinics serving 1.5 million people in the second scenario. So in other words, with domestic financing alone, we would still be able to meet Penn Plus regional targets for initiation, but with much lower numbers of people actually benefiting from care. Next slide. And we need to remember that we are talking about here are largely children and young adults who would otherwise die without this care. Almost 80% of our case mix was under the age of 40, and almost half was under age 20. Effectively, blended financing doubled the number of lives saved over a 10-year period from 126,000 to 265,000. Next slide. When we looked at the cost side, we found that the annual cost of scale-up was around $0.6 per capita. And we know, many health systems, say are spending about $50 per capita, and government resources often much less. Human resources accounted for the greatest part of this cost at 35%. And remember, this is an efficient, task-shared operation. And we know that in many countries there's an issue actually with health worker underemployment. So this is really an investment in health systems. On the consumable side, medications accounted for only 6% of costs, and all consumables combined accounted for less than 15% of costs, including sickle cell screening. But remember that this is using reference pricing, and we know that actual costs in many countries are much higher than this. So it'll actually take efforts to get prices to this level. Finally, we were able to estimate the additional cost of blended financing for low-income countries, which scales to $201 million by 2030, but only $29 million of this was in consumables. And for all countries combined, the total additional cost in 2035 of blended financing was $553 million, of which $82 million was for consumables. Next slide. So what we have here is a generational opportunity to not only meet the regional Penn Plus targets, but to save hundreds of thousands of young lives. The benefits of this investment exceeded the cost by more than 4.5 times in dollar terms. And this is comparable to other best buys for NCDs, including, for example, the Hearts package. But the advantage of starting with Penn Plus in Africa is that we are starting with saving the lives of children and young adults. We're investing in leadership and strengthening of health systems, and we are challenging the passion of a global community of people living with these conditions. Next slide. In September of 2024, the NCDI Poverty Network and its partners published the NCDI Poverty Network's 2025 to 2028 strategic plan for Penn Plus expansion. We committed to supporting countries to expand access to quality Penn Plus services and to raising new money to address gaps in Penn Plus financing, particularly in low-income countries. And since that time, we have seen an explosion of new organizations coming in to support Penn Plus throughout Africa. The opportunity here and the responsibility in Africa is to channel these services, this additional support, so that it reaches patients in their homes. So this year, in addition to the reminder, next slide, from our Kango cloth, the solo budi hutendwa, what must be done will be done, we should add a quote from Julius Nyereri's 1963 translation, it's incredible, of William Shakespeare's Julius Caesar, which he wrote at the dawn of Tanzania's independence. Next slide. Hopefully I don't say this too wrong. Majambo ya bindamanu ya nakujwa nakupwa ya kindakwa ya jema hungozia ya ishindini. Yeah, and we know this one from Shakespeare, that there is a tide in the affairs of man which, taken at the flood, leads on to victory. And I think that we are at a moment like this right now in Africa. Lisolo Budi Hutendwa. Asante.
Sur cette note, et puis je vais terminer mon exposé. Je vous remercie.
That means what must be done, what must be done. Is that correct, Jean? Thank you, Jean. Thank you for that presentation. Again, we are saying we have a problem in Africa. Rising burden of non-communicable diseases, severe non-communicable diseases, affecting especially children and young adults, and of course, older people. What will it cost? It's saying to take the proposed solution or the ongoing solution of Pain Plus to scale will cost less than $1 per capita per head, about $0.6, and that the savings, the investments cost exceeds more than 4.5 times. So it's worth investing, especially within the context of health systems and primary health care. And that takes us to the next presentation by Dr. Guy, who will present on PSC-oriented health systems approach. And we'll be looking at the global perspectives on strengthening NCD response through primary health care. We'll be looking at the integration of NCD services into primary health care systems. We'll be looking at best practices and policy and systems level actions. Dr. Guy, it's your turn. Thank you.
Thank you very much. Good morning, distinguished guests, colleagues, partners, friends. I see many in the room. It's a real pleasure to join you in this important celebration of the successes and lessons learned of WHO PEN and PEN Plus. It is so important to be here, listening, learning, and collecting the many experiences we're going to be hearing across the 3 days, but we've already had a brief insight across these two presentations. The successes, lessons learned, insights on how we at the global level can shape better, effective, inclusive, equitable responses that can support not only the African region but other regions. It is, and congratulations to those who have hosted and convened this third iteration of the conference. It's exciting. Looking forward to listening to those lessons learned. And excellent presentations from Kofi on the regional landscape, which very well translates into global data, global conclusions, global trends. Some of them ambitious, but many of them challenging as we look into the latest data coming in through our global monitoring and surveillance platforms. I'm here
de surveillance. Aujourd'hui, j'aimerais partager et contribuer également les discussions que nous aurons dans le cadre de la stratégie PEN+, contribuer à travers l'initiative mondiale que nous allons lancer très bientôt sur comment nous, au niveau de l'OMS, nous pouvons contribuer ou soutenir les pays dans l'offre des services intégrés des MNT au niveau des soins des services primaires à travers les approches de renforcement des systèmes de santé intégrés dans l'approche de santé primaire. Et je vais vous en dire plus sur ces points durant la présentation des diapositives à venir. Kofi a été très brillant dans sa présentation. Prochaine diapositive. Kofi a été très excellent dans la présentation de l'impact des MNT ainsi que le poids de ces MNT dans le système sanitaire ainsi que l'impact pour notre région africaine. Et nous savons tous que les MNT sont des causes de mortalité et continuent d'avoir un poids important sur les systèmes de santé dans les familles. Et ces MNT se retrouvent être parmi les 7 premières causes de létalité au niveau mondial.